Hi everyone! Thank you so much for watching to another virtual shouting session. Today here we have Dr. Emily Andrada. She is a professor of Pediatric Emergency Medicine and she works clinically at the Emergency Pediatric Department at the UC Davis Medical Center, and I'll have her take it away. Thank you, Dr. Andrada.
You're welcome. Thanks for inviting me. I'm excited to chat with you guys today. I know that this is being recorded and that you are going to be posting this. So I just wanted to, before we start, make clear with a disclosure that none of the images I'm showing are of actual patients, that these are all images that I pulled off of the web. If there are any stories that sound similar to someone's personal story, know that that is just a coincidence. What I've tried to do is just give you a flavor for what we do in the Pediatric Emergency Department. I want to thank Alyssa for sharing some exemplars of successful presentations in the past. So one was a medical student at Stanford and the other was a family medicine chief resident at Kaiser. And it was super interesting listening to those or watching those videos. And what I wanted to try to convey today was how unique and different the Pediatric Emergency Department is, how different the pace is, and kind of the different thought process that we go through. So let me share my screen. Okay, hold on. There's a lot of screens up. Okay, can you guys see this? Okay, and let me, while I'm setting this part up, can you guys get onto a mobile device, so your smartphone or an iPad, and you're going to go to slido.com. And I'm gonna try to be able to see you guys too. Whoops. Okay. All right, can you all see my screen? Okay, and let me know, I'm gonna just go to the next slide, which is just to make sure that your Slido is working. If you had to choose forever and ever, would you choose Adobo or Synagogue? And it looks like we have we have 4 of you, so we'll know. So there's the counter in the top right that tells me if you have all turned in answers or not. Wow, Synagogue. Wow, I would not have guessed that. My vote would have been for Adobo. Very interesting. Okay, now I know what to make when you guys come over for dinner. All right. Okay, so if you like, there's going to be questions kind of scattered throughout these cases that I'm going to just have you answer, but also it's fun to hear from you. So you are welcome to unmute through the presentation whenever you want, except for Alyssa, only when you're talking because your washing machine is going. Okay, so this is the first case. We have different levels of trauma activations in the emergency department. For our particular facility, we have 4 levels. So 911, 922, 933 are all trauma activations. We are a level 1 trauma center. In addition to that, we are a level 1 pediatric trauma center, which means that we have kids that are transported from the scene of the injuries past multiple other hospitals to come to our facility because we have all of the pieces in place to help take care of very high acuity injuries. So that means there is an OR that's always held open. The blood bank is ready. We have anesthesia ready. We have surgeons that are ready. The emergency department is prepared. We have rapid infusers and just the expertise to be able to resuscitate kids that come in under duress from injuries. So This particular case is a 911 trauma activation. This is a 6-year-old female who sustained a penetrating left injury to the left knee. After dinner, the family turned off the lights to play a game. They had been eating cake, and then she was crawling underneath the table and felt this stabbing sensation to her left knee. We ended up getting an X-ray, and this is what we saw. Something is there that doesn't belong there, clearly. So the question here is, what do you notice about this image? And we will go here. What do you notice about this image? And you can put in whatever things that you notice. And then after you enter on your mobile device, you just hit submit. So maybe there's an issue with Slido. Can you guys unmute and tell me if there's an issue with submitting? Oh, there we go. Okay. Yes, there's an Eiffel Tower in the knee. Excellent observation. A figurine or object that looks like the Eiffel Tower is lodged into the knee. That is correct. Right. So what you can see from, so this is a plain X-ray. Plain X-rays differentiate things in the body based on density. So you can see that the bone is way more dense than the skin. That's why the bones are easily visible. And then it's clear that that Eiffel Tower is something even more dense than bone. It's probably metallic because it's so bright. And it is somewhere in the vicinity of the knee, and not only the knee, but the knee joint. So if you look at my cursor, what you see is this is the distal femur. So the bottom of the femur and the condyles. Okay, and then this is the fibula here, and then the top, the tibial plateau, and then the rest of the tibia here. And then this metallic Eiffel Tower is somewhere between the femoral condyles and the tibial plateau. And so what are the structures that we think about? I mean, these are sort of anatomically thinking, these are the things that are running through our head in the emergency department. Well, anatomically speaking, between the femoral condyles and the tibial plateau are the meniscus, right? So this is sort of the cushion pads that the condyles kind of rotate on. This thing that's an X in the middle are the cruciate ligaments, right? So we think about these a lot when we see, you know, basketball players and football players injured. This is in particular the structure that is torn. And then this sort of pink outline and whiteness in the middle, this pink outline here and whiteness in the middle, what you really want to imagine is sort of a 3D surrounding of what is essentially the synovial joint, right? So the synovial joint is basically a balloon that encompasses the bottom of the femur and the top of the tibia and the structures in between, and bathes that area in fluid. So that is the joint. Now the concern is that this metallic object is in the joint, right? So here, even on, this is called the lateral view, clearly there's some concern that this thing may have compromise the joint, right? So if we're looking at the same picture, the patella is here, the distal femur is here, the top of the tibia is here, and that metallic object is somewhere in this vicinity, right? So if we think about layers, this is the skin out here, this is the bursa, that's the patella, and then now we get into, you know, essentially the joint itself. Now, the problem with foreign bodies, like, you know, an Eiffel Tower that is randomly laying around on the ground, is that it is dirty, right? And the joint is sterile. And so this could potentially have introduced some infection into the joint. And we need to know that, because if that is the case, this patient needs to go to the operating room with the orthopedic surgeons to get washed out. So the joint gets irrigated out, gets cleaned out. They get placed potentially on IV antibiotics. And we try to figure out if that is the case. So the way we figure out if the joint is compromised, is to inject the joint. This is called a saline load arthrogram. We get underneath the patella directly into the joint, and we inject about 150 to 200 cc's of fluid. And we look to see if where the puncture is, if there's fluid leaking out, right? Because if there's compromise to the joint and we load the joint itself with saline, you should start to see some leakage out of the joint, right? So the care that is organized for this patient in the emergency department includes, obviously an immediate X-ray of the knee to look for not only, to essentially look for bony injuries, but also to see the position of the foreign body, obviously to provide the child some pain control, to do a saline arthrogram or a saline load test. In this particular case, the test was negative, and so the penetration of that foreign body just went as deep as the soft tissue. Then we cleaned up the wound because we knew that the joint itself had not been compromised. We made sure that the patient's tetanus was up to date, right? Because of those, tetanus spores just sort of live in the soil. They get tracked in by people's shoes, and then they can kind of be on these inanimate objects. And then we worry again about these kinds of infections being introduced into people's bodies. And so we make sure that their immunizations are up to date. We give a dose of antibiotics, and then, if it really is just a soft tissue wound, we potentially discharge them. So this, again, requires a lot of people, not only the physicians in the pediatric emergency department, but also the trauma service, the orthopedic surgeons, radiology, nurses, and our techs. Okay, on to the next case. This is a 6-month-old who has a rash to the trunk. The 6-month-old has had it there for 2 days. Has not been better with Desitin, which is basically that baby diaper rash cream. The baby's otherwise been normal, eating normally, acting normally, no fevers, no vomiting, and no coughing. And this is what you see when you examine the baby. And so what do you notice about this exam? Okay. Okay. So there's a rash on both sides of the baby, but not in the middle. Rashes on both sides of the baby's back. And is it bumpy? Like if we could feel it, would it be bumpy? So let me just go back to that image, right? So yeah, so you can see there's, the baby is pretty fair skinned. The rash itself, you can maybe comment on the color. It's sort of a brownish or hyperpigmented rash, and it spares the middle, but it's definitely involves the sides of the back. And so what you want to recognize here is that there is actually a pattern. And the pattern is, if you imagine the baby in this particular position, right, sitting on mom's lap, facing mom, and if mom put her fingers around the baby's torso, that's exactly where all those marks would land. And so this particular rash is something called phytophotodermatitis. And if you dig in history a little bit more, what you're probably going to extract is a history of the family having some sort of citrus, lime, or lemon. Also parsley and celery can do this. And what these foods have in them are something called psoralins. And so this gets on the family member's hands, and then wherever they touch, it sensitizes the skin. And then when the patient gets exposed to sun, that area that gets touched and with psoralins becomes hyperpigmented. And so they often call this like Margarita rash, right? Like as if you've been preparing margaritas, and in this particular case, he wasn't doing a good job of swallowing it. He just let it run down the front of his body, and then got exposed to the sun. And then this is that area that got totally sensitized by that. On the right side of your screen is a kid that had been making lemonade and helping squeeze some lemons. And then a day or two later, after some exposure to the sun, because of the psoralins in those particular foods, got sensitized and so developed this very red rash with even some blistering on there. So phytophotodermatitis. All right, so, obviously that case involved really just the know-how of the pediatric emergency department and our nurses, and we didn't have to consult anybody in that process. All right, any questions about that case? Or the previous case? Okay, all right, the next case is a 3-year-old with a sore throat who was brushing his teeth. He kept his toothbrush in his mouth, and then he tripped over his dog and fell directly onto his face with the toothbrush. The toothbrush then got impaled into the back of the throat. We actually see this quite a bit with all kinds of things, pens and pencils and all sorts of stuff. All right. This happens, at least twice a day if you're brushing your teeth the way you're supposed to. There are lots of things you learn as a pediatric emergency medicine doc, which is like a bazillion things that you want your kids to not be doing. And so this is the injury, right? So this is the exam of the back of the throat. You can see here, this is an instrument that's holding the tongue down. That's the uvula. This is the palatal arches, and then the posterior oropharynx behind the uvula. All right, and then this is your soft palate, and then your hard palate, and then you can see sort of the molars, the top molars. Okay, so what do you wonder about the position of this injury? So good question. Has it pierced any important blood vessels or nerves, right? So it's important to know what the structures are behind the palate. Good. Again, concerns about the blood vessels or nerves that are very close to the posterior portion of the palate. How severe was the trip in order for the toothbrush to be impaled, or how did he trip over the dog? Yeah. So all good questions, right? And so a lot of what we do in emergency medicine is to ask these sort of like detectives questions of the families that aren't leading. So lots of good questions that get to that point end up being, when was your child last well? Or what happened just before the fall? Oh, he was brushing his teeth. And was he, and was the patient completely fine before that? Yes, they were totally fine. So now you're good until like the point of teeth brushing. And then you can ask, and then what happened next? And then what happened next? And then what happened next? And then you will get a play-by-play, a description of, what you need to know about the mechanism of the injury itself. Okay. So in order to answer your questions, those are great questions. You want to understand what the structures are, the anatomy of what is behind the palate. So this is a CT scan. And remember, in a CT scan, what we're looking at, like, you want to pretend that you're standing at the patient's feet and the head is the furthest away from you. And what the images are doing is they're taking slices of the body towards you, right? And so you're looking at one cut, and this particular cut is exactly at the level of the lower teeth. So the mandible, the lower teeth, and then the posterior oropharynx, so like the throat area, and then the cervical spine, right? So this is the patient laying on their back. So this is their neck, right? That's the cervical spine. This is the airway. This is the tongue. The tonsils are in here somewhere, and then the bottom jaw and the teeth, right? And so we imagine that the toothbrush is kind of coming in some trajectory through the bottom, through the mouth, and then at the back of the throat, what you want to recognize is that this green area here is the carotid space. The carotid space holds the carotid artery, and nerves course through that area as well, but big red lives in there, right? The carotid artery. So on either side, so lateral on the palate is where you need to worry about blood vessels. So if you go directly posterior, you're basically going to be in the posterior oropharynx, so the back of the throat, and then directly onto the cervical spine, right? So the vertebral body right here. So if you have a puncture that is lateral, you need to worry about the carotid. All right. So this is not this kid, but this is a toothbrush that was stuck because it was so far impaled into the back of the throat. Okay. And so this is a sagittal view. And then if we look at the same view compared to just normal anatomy, you can see that the toothbrush is tracking back, 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 and it basically slides between the cervical vertebral body and the carotid space, right? So like on the normal image, it was basically just slid between these two structures, right? And so what we get concerned about in kids that have puncture injuries to the backs of their throat from whatever they were holding in their mouth is if they have a lateral puncture, we need to worry about an injury to the carotid space. And so how do we figure out if there's an injury to the carotid is we need to get a CT angio. So this, but the angiogram part of it is that we inject contrast and then we're able to see what the vessels look like as they course through that space, right? Because if there's injury to the vessel, if we see contrast leaking out into the soft tissue space, or if we see a clot forming in there, that's a problem, right? There's been some injury to the carotid. If there's a clot forming in there, that potentially could embolize, right? So it can move directly into the brain and cause a stroke. But that's sort of the main concern when we're dealing with lateral palate injuries, right? And so this is a reconstruction of the CT angiogram. And this person, very, very lucky. Here's the carotids and the toothbrush stops just short of injuring or impinging upon the carotids. Very lucky. All right. So what this required in the pediatric emergency department was really an exam, right? So like one, if you actually have a foreign body impaled in the posterior oropharynx, you really need to make sure that the airway is patent, right? That they can breathe and protect their airway. Because of the concern about clots, potential clots in the carotid and maybe embolization. So the clot getting loose and moving into the brain and then blocking blood flow. We want to make sure that they have a normal neurologic exam. We can listen for exam findings of any disruption in the carotid by listening for something called a bruit, which is basically just very turbulent flow in the carotid. We can look for an expanding hematoma. So if there's actual injury to the carotid and it's bleeding into the soft tissue, you can see that externally because you may have a blood collection that's continuing to expand. And then certainly any active bleeding in the mouth. Pain control always, right? This is a very uncomfortable injury. And then we call on our friends, the ENT surgeons. They also go by otolaryngology. So these are the ear, nose, and throat surgeons. They focus basically just on everything from the neck up in through the face, excluding the brain. CT imaging, so CT of the head, but also a CT angiogram with contrast to evaluate the blood vessels, making sure that the tetanus is up to date. And then if everything is fine, the CT angio is fine, this, the foreign body is out, ENT maybe has repaired the hole in the back of the pharynx, potentially that kid could go home, right? So it's just, again, this very coordinated dance of us plus our consultants that we rely upon to help combine all our skills together. And then again, also radiology. Okay, questions about that case?
Dr. Andrada, I wanted to ask, with the trauma, how long would you expect that recovery to be, and like, what would be the proper treatment? Because I'm pretty sure they still have to eat and drink and yeah.
Well, what we would tell the families that the mouth actually has really great blood supply. So those kinds of mucosal injuries on the palate, they actually heal very quickly. What you want to do is give at least 2 to 3 days for that thing to close. Like if it's a really big opening, then ENT will go in and sort of close it with what's called an absorbable suture, right? So a suture that holds it together, but just will kind of absorb on its own. And it's not a suture that we have to clip out. if it's relatively small, it will probably seal on its own, but you want to, in the meantime, avoid introducing things into the mouth that are going to get lodged in there. So we tell the families, avoid sort of crunchy, hard things that might get stuck in there. Go with like soft foods, so like yogurt or mashed potatoes, or ice cream shakes, or just ice cream for 2 or 3 days. And then, if the kid is developmentally able to sort of gargle and keep that area clean, we have them do that. If they're not developmentally, like if you're 2 or 3, you're not gargling, you're putting stuff in your mouth and you're going to swallow it, right? So we just tell the family, lots of just kind of clean water, fluid, just to kind of keep that area as clean as possible, usually 2 to 3 days, and it seals down.
Okay, thank you.
You're welcome. Okay. I will just say that all these cases that we're talking about are facsimiles of real cases. This is what we see. Like, we see a lot of high acuity injuries and illness, but we also see the full spectrum of like, I just want a well child check on my kid, and there's absolutely nothing wrong with them. I just want you to check them. Okay, we do that too, right? So the full spectrum, which is really kind of cool. And then the other thing is that in our department, in our facility, we see up to the 21st birthday. So we're seeing kids that are basically 0 to 20 years of age. Okay, this is also a real case. This is a 911 trauma activation for penetrating trauma to the eye. So it was a 10-year-old female who had gotten a package that had string around it, and she was cutting it with a knife, with the blade facing up. And she cut through the string, but she was using enough force that she like flicked the knife up to her eye and stabbed her eye. And then, this isn't her, but this is a very similar exam. Okay, so look at this eye and tell me, your pictures are underneath it. So what do you wonder about this exam? Good. Is the retina damaged? The other question is, where is the retina, right? In the anatomical position compared to where the injury is. Great question. How has her vision changed? Good. Did the blade pierce the eye and then maybe extend into the brain? Good. Has the brain been affected? Okay, excellent. All really good questions. So again, all questions that, one, we can answer with an exam, but also with some understanding of what normal is and what sort of normal anatomy should look like, right? So on your left-hand side is a normal eye, her normal eye, and on the right-hand side is the affected eye. And so what you want to remember is that the iris, so the iris is the colored part of your eye, is really a muscle, right? And it will dilate and constrict based on how much light is surrounding, is being inputted into the eye. So it's not really tethered down to anything centrally. And then what you want to recognize too is that normal is round, right? So pupils are normally round, and this pupil, the abnormal pupil on the right, is clearly not round. It's what we call a teardrop pupil, right? And then there's something up with something on the surface of the cornea there, on the surface of the eye, and it looks strangely similar to the iris, right? So like this little bleb right here, it looks like the iris, but it's more external, right? So that is where she punctured her eye, and that is iris coming out of that puncture hole, okay? So when we see these, when we hear about penetrating injuries and we go to look at the eye, this is a clear sign, a teardrop pupil, that there is a globe injury. We call it also a ruptured globe, and that what the iris does in response to penetration of the globe is to get pulled over to that puncture, and it seals it, right? So it basically, because it's free floating in the center, that area that gets punctured, it basically sucks the iris up into it, and it it plugs that hole, right? Because the globe itself is basically just full of fluid, right? So if we're looking at the eye, a cross section of the eye, it's really just this thing called the vitreous humor, and then the lens, and then the iris is here, right? So the iris, if you imagine it in 3D, the iris is here. It's not tethered down centrally, it's tethered down peripherally. And then your cornea is here, right? So she gets punctured somewhere at the edge of the cornea or right on the globe itself, right? And it's just like, imagine a balloon that's full of water, right? And then this iris just gets yanked over to help plug that little hole, right? So these ruptured globes are very, very tough because it's amazing that how little you can do once you rupture your globe, right? So if you rupture your globe, and then actually to answer your questions about the retina is way back here, right? So that puncture of the globe has probably not reached the retina, so you're not worried about that. But if you don't have your vitreous humor in here, and it's not something that you can actually replace, right? So if you puncture this, you can seal that, but you're never going to have the same kind of inflation on the globe, and you lose your vision in that eye. So she lost her vision permanently in her eye, right? From that one weird, like, I was just opening a gift and I poked my eye with a knife, right? So she's not going to get the vision back in that eye, which is really, really kind of sad. Okay, so when they first roll in, we do a very thorough eye exam to look to see where those injuries are. A Fox shield is just a stiff plastic or metal shield that we put over the eye so that the eye doesn't experience any more pressure until it gets definitively evaluated by the ophthalmologist. Pain control, tetanus, we make sure those are up to date. If we think that this is a dirty wound, then we'll start some antibiotics, and then ophthalmology will go to the OR for the ruptured globe. And then if it's a traumatic, not just a penetrating straight, but if we're worried about foreign bodies stuck in the eye, or if it's sort of a blunt trauma to the eye, like a fall or a motor vehicle crash, then we'll typically get some imaging. So it's us, it's trauma surgery, it's ophthalmology, radiology, nurses, and our techs. Okay, questions about that?
So her eye stayed that way forever?
Well, they repaired the penetrating wound, but the vision did not come back.
And
right,
so it looked like that teardrop kind of dealio.
So they pull the iris back out, right? So they pull it out of the puncture wound, close the wound, but the globe remains deflated, and then the vision in that eye gets lost. Yeah, it's sad. It's very sad and tragic. So again, like, this is like, number 23 on the list of things that my children, where I got real crazy with my kids, like, no knives, if you hold a knife, the blade goes down, like kindergarten scissors till you're 20, that kind of stuff. So you get really emotionally traumatized by these kinds of things, for sure. Okay. This came in the other night. This actually came in the same night as the puncture wound to the knee. They came in literally within 5 minutes of each other. So this is an 8-year-old female who was at home, minding her own business, walking down the hall. She was just passing the bathroom door, which was closed. And then something exploded in the bathroom and blasted out the bathroom door. She was facing the door, and then she sustained blast burns to her face and her thighs because she was wearing shorts. Okay, so this is not the real patient. This looks similar to the patient on her face. Okay, what do you notice on this exam? Good. So her eyes were spared. Good. You see the skin. You don't see anything underneath the skin that was exposed, like muscle. You don't see any bleeding in the burned area. Good. Okay. So let me see if I have it forward. So if we go back, so yeah, so the things that you want to notice about this exam are, basically what burns can do, right? So when we talk about primary, secondary, and tertiary burns, or third degree burns, primary, first degree, second degree, and third degree burns, you're basically looking at levels of skin that are involved, right? So a first degree burn is basically what you would recognize as a sunburn, right? So if you just get really red on your skin and it can be a little bit sensitive, that's a first degree burn. The second degree burn is basically a partial thickness burn, right? So there's a certain thickness to the skin itself, and it involves those very superficial cells, and then sort of deeper tissue, and then underneath is sort of like muscle, nerves, blood vessels, that kind of stuff, right? So again, first degree, like a sunburn. Second degree is some degree of partial thickness, right? Like it's not superficial and it's not all the way through, it's something in between. And typically the finding on the exam is kind of what this looks like, right? Like it just looks like the rawest exposure of skin because that top layer is off. Other things that you might notice on a partial thickness burn is that there may be a blister overlying this, right? So like that top layer is basically devitalized or dead. So it just sort of lifts, and then there's fluid that kind of collects underneath it. But it does have sort of this raw pink and kind of wet look to it. And then the third degree burns, because they go all the way through and they involve the nerves, that does not hurt, which is worrisome, right? So if it's a full thickness burn, that affected skin is super tough and leathery. Like it doesn't have that normal pliability to normal skin or even a partial thickness burn. It's hard. It's usually very discolored. So folks will describe it as like very sort of wood-like or sort of very white and discolored. But there's no pain there because the nerves are completely gone, right? Okay, so this is a partial thickness burn. This is what happened to the gal that we saw, right? So she got second degree burns on her face, and then she also got this singeing. So this is what happens when hair gets burned. You get this sort of weird, sort of curly Q, dry change to the hair. And so she had it on her eyebrows and on sort of up along the area of her top of her forehead. And then the other really important places that you want to look is in the nose, right? So like the nasal hairs. And this all helps to give you a sense of like how hot was this burn and how close was the patient to it, right? So if you have nasal hair singeing and eyebrow singeing, like you were pretty close to the source of that. Sometimes the heat can be so intense that you have no hair in your nose, right? So, and all you have left is like soot. And so that again tells you like, like that was, you were really close and it was really hot, and maybe your airway is going to be affected. Maybe you're going to start to develop some airway edema. But again, like you want to pay attention to the parts, like the forward facing parts of the body that were affected. And so it's good to look for areas of singeing, and the patient that we saw definitely had it. So again, first degree burn, like a sunburn, no biggie, that's gonna heal. Second degree burns. And so this is what a burn looks like on folks with a lot more pigment, right? So it sort of more has this sort of gray discoloration, and then sometimes this blistering. This is all devitalized skin, right? So one of the things that we do in the department is when we see second degree burns, we'll clean the burns up, meaning we'll get all of that devitalized dead skin off because it contributes later to scarring. So you want to get all that dead skin off so that when it heals, it doesn't heal over skin that is essentially dead or devitalized, and that causes a little bit more scarring. So in fact, what the way to debride this is actually to just get sterile saline and sterile gauze, and you just press and wipe, and all that dead skin just wipes off. Like it has no more ability to sort of stick to normal skin. It just peels off. All right, so that's a second-degree burn. Okay, so the other really important thing that we deal with in burns is to figure out, like, what is the body surface area involved, because then that determines how aggressive we need to be about fluid resuscitation. So if you've taken physiology, you'll remember, like, the skin, it plays a huge role in holding moisture and keeping your in the body and keeping your body hydrated. And so if you're losing, big swaths of skin, your body is really not able to maintain hydration. And then you also have issues with temperature regulation. And so the magic number here is usually around 12 to 15. So if you have 12 to 15% body surface area of either second or third degree burns, then we move to aggressive fluid resuscitation, because on down the line, as you continue to get managed in the hospital, you're gonna sustain a fair amount of fluid loss, right? So the way that we make these estimations is, if you look at the adult figure on the left side, we call it the rule of nines, right? So you see this sort of front back is 18 and 18, and the legs are 18. So it's like 9 in the front, 9 in the back. The arms are 9 all together, and then the torso is sort of like 9 and 9 in front and 9 and 9 in back, and then the head is 9. Okay, but then when you deal with kids, what you want to think about in kids is that they don't have the same proportions as adults. Like, kids have gigantic heads, and then they have their body, right? So they don't have the same proportions. And so we can't apply these same rules to kids. And so you either have to refer to diagram like this, or the one thing that I think is super helpful is to remember that in kids, their palm, including their fingers, is 1% body surface area, right? So you just sort of like take their hand and be like, okay, their hand's like that big, and then you just go on their body and you're like, okay, 1, 2, 3, 4, 5, 6, 7, 8, and you just guesstimate, right? You don't have to be like spot on. You just need a general estimation in the neighborhood of what the body surface area involved is. And then you can make some clinical decisions from there. Remember too, that you're only counting second and third degree burns. We're not counting sunburn areas or first degree burns, right? Like, that does not need fluid resuscitation. Second and third degree burns do. All right, so if you breach that threshold, 12 to 15%, somewhere in there, what we apply is this thing called the Parkland Formula. Okay, so we're at 12 to 15%. So the formula is just this: 4 milliliters times your body surface area percentage times your body weight. And you take that volume, you cut it in half, you give the first half in 8 hours, and you give the second half in 16 hours. And that just provides you adequate hydration for the amount of fluid that we expect you to lose because of the extent of your burns. So that's a formula that we rely on quite a bit. And then just a word about this explosion, right? So this explosion happened because an irresponsible adult in this person's family was making drugs, was making butane hash oil in the bathroom, right? And so you may know that it's quite common now for people in their homes to turn their homes into labs where they take cannabinoids and they basically use butane oil to concentrate and extract the cannabinoid, the THC, and they can make this very highly concentrated THC butane hash oil, right? But it went really south for this adult family member and exploded their bathroom, right? So on top of this girl's injuries, the burns, we also now have to deal with the situation in the house, which is unsafe, right? Where adults are making poor decisions for kids. And so when we're dealing with those situations, which happens unfortunately quite often, we get help from our social workers, which we have in the emergency department 24 hours a day. And they are our liaison with Child Protective Services and law enforcement, right? So it turns out in this case, like law enforcement was out on the scene, the adult family member was arrested, and then, you know, it turns out that, you know, unfortunately, the patient's mom was sort of complicit with this. So all the kids got removed from the home and all got put into foster care that night, which was, you know, sad, but you know, safe for the kids, right? Like that is not a safe home situation for the kids to return to. So again, lots of people involved in the care to like make sure all these pieces that require attention get the appropriate attention. So a blast burn to the face requires an airway evaluation. So we're making sure that the child doesn't have any hoarseness and that there's no soot back there and that there's no progressing edema in the upper airway and that they can control their airway and secretions, which she could. We estimated the body surface area involved. It was under actually the 15% that required aggressive fluid management. Pain control is a big deal, right? These are very uncomfortable injuries. We took care of her wounds. Because of the involvement of law enforcement and child protective services and the issue at home with the hash oil, we needed to drug screen the kid to make sure that somehow the kid didn't also have drugs on board because of being around, just, you know, in and around the house. The patient was on something called a blackout. So when we put kids on a blackout, it's because there are people on the outside of the hospital that are trying to get information on the kid, not for great purposes. So if someone called into our emergency department looking for this kid, because this kid was on a blackout, they would say, we don't have that kid here, right? So it's just a way to protect the kid. And then the protective custody piece is worked on with in concert with our social workers and child protective services, and then our own professional opinion about you know, injuries and sort of the safety of the child for home. Okay, questions about that?
Hi, Dr. Andrada.
Hi.
I will say thank you for all the multiple case studies you gave us. I just want to let you know that we have about 20 minutes left of this session.
Oh, okay.
And that we
Okay.
still have the Q&A portion to do.
Okay, thank you for reminding me. Let me see what else I have left. Let me work quickly through this one. This is an 8-year-old that had a rash. That's what the rash looks like. This sort of round red thing with these heaped up edges. This is a similar rash here that sort of has this sort of scaly, dry look to it. This is also the same issue, right? So that is essentially ringworm, which is what we call tinea corporis. It's a fungal infection. It can also get into the hair and the hair shafts. It can cause hair loss, but also this issue here, which is called a carrion. So this looks like a big ball of a bacterial infection. It's actually a big collection of fungus that doesn't respond to antibiotics. And so these kids need to go on oral antifungals. And then for the ringworm on the body, that is a topical antifungal that we place on them. This is a case about belly pain, intermittent belly pain and bloody poop. And the issue here is this diagnosis called intussusception. Intussusception is where the bowel telescopes in on itself. And so if you take a cross section of that, it looks like a target sign. So and here, that's what that target sign looks like. This is really common for kids under the age of 2. They'll have intermittent abdominal pain, vomiting, and then at the end part where there's dying bowel in here, they'll have bloody stool. This is what it looks like to reduce it. So they basically put a catheter into the rectum, inject a big column of contrast from the rectum up the descending colon across on the transverse. They meet the intussusceptum here, and then with pressure, they push it back, right? So they straighten out that telescoped area, and then you get contrast all throughout the bowel. So our pediatric radiologists come in to take care of that. This is what happens when you have to go to the OR to get it reduced. They just straighten it out. They pull it back out. They straighten out that telescope area. And then again, nice coordination with pediatric surgery, pediatric radiology. And then this last one is a kid that has leukemia, comes in with fever, just had chemotherapy a week and a half ago. This is, I just want to make the point that we often see kids that have indwelling hardware. This thing is called a Broviac catheter. It is a central line that sits, the tip sits in the right, it's in the subclavian, sometimes into the right atrium, and then tracks out to the skin here, tunnels under the skin, and then you see these two external ports, which is what it looks like here. And then that's how kids who get a lot of blood draws and get a lot of infusions can avoid just getting poked every single week. Kids that have chemotherapy have very, very low white blood cell counts. And in particular, what we want to know about them is what is their neutrophil count, because neutrophils, as you know, fight bacteria in all these important ways. And if they come back, this is the calculation, their white count times the percent neutrophils plus bands. And if they're very, very, very neutropenic, under 500, those kids need antibiotics and to be admitted. Okay, ready for questions.
So one of our members would like to know, what is the average amount of time you're at work? And is there any flexibility in your schedule, if anything?
Oh yeah, that's a great question. I am full-time faculty. So full-time academic faculty is 144 hours of clinical time a month. That ends up being somewhere around 14 to 15 10-hour shifts a month, give or take. If you're academic faculty, a lot of us have what we call buy down. So you have research that provides funding, or you get some other compensation from, say, the School of Medicine or other departments, and you can buy down some of your clinical time. So I work about 12 to 13 shifts a month, and I have some buy down because I oversee the pediatric emergency medicine education for our emergency medicine residents. So, and then to the question about whether or not it's flexible, it is literally the most flexible job in the world. So it's shift work. We work 24/7, 365. No, there is no sacred day or time of day ever. So if you decide, well, I need these 3 days off, but I can work 5 nights in a row, you can do that. Or you can say, well, I only want to work nights. You can also do that. Or you can say, I want to work every weekend, but only Sunday night. You could also do that. So it's super duper flexible. As I like to tell my husband, even though I work full time, I am home a ton. And isn't he so lucky? He thinks he's lucky.
Hi. So I just wanted to ask what your undergrad and residency were like.
Oh, what they were like. I went to undergrad at UCLA. Do you mean undergrad college or undergrad in medical school? Sorry.
Whatever you feel is most appropriate.
Oh, okay.
Want to talk about?
Got it. So I went to undergrad at UCLA, but then I went to medical school at UC Davis and then residency at UC Davis. And then what were they like? So at UCLA, when I went, I have 2 older brothers. And we're all Filipino, so I can say all these things to you that you'll understand, right? And my dad was a surgeon, my mom's a nurse, and so my brothers were supposed to do what all older, the first and second children of Filipino families do, which is to also do exactly what my dad did, right? Like, you will become doctors, that's what you do, right? And so my oldest brother, well, long story short, neither of them did that, right? And my parents, they put a lot of stock in my brothers that they were going to be doing. They had these expectations for them, and they'll tell you now they're fine now, but I'm just saying, like, they both got put on academic probation, like their first years in college. My oldest brother transferred because just things were not going the right way. And he eventually figured it out, right? And so he has a PhD in statistics. He's very functional. He's married, he has kids. But he medicine was not really the thing that he loved. My next brother also, again, had academic trouble at the beginning. And then what fired him up was some guidance counselor at UC Riverside that was like, what do you want to be? And he's like, I want to be a doctor. And they're like, that's not happening. And then he walked out of there and he's like, oh, watch me. So he ended up going to dental school and has a thriving practice in San Diego, also married, also has kids, very, in his way, he's functional. He's both great brothers, but, did not do exactly what my parents thought. Now, the response because of that, I think because my parents were a little bit traumatized because things didn't quite go the way they planned, was to then weirdly drop the bar when it came to my sister and I, who my brothers will tell you that we are way smarter than them, right? They're like, now the smart people in this family are Emily and Elisa. So, but my parents are kind of like, well, this med school thing, it might be kind of hard. So, don't, put all your eggs in one basket. So when I went to UCLA, what I did was what my parents told me to do, which is to go to nursing school. And at the time they had a bachelor's degree. And I was like, okay, fine. But I'm telling you now, I want to go to medical school. And they're like, yeah. But, you can go to med school, but, like, just so you have something to fall back on. And I was like, okay, fine. So I did my first 2 years at UCLA. I applied in the school of nursing at UCLA. I got in, I finished. I knew the entire time that I was going to, as leading into that, I was like, I'm not going to take the nursing prereqs. I'm going to take the med school prereqs, because it's going to count for the school of nursing, and I'm going to have them done, So I finished, and then I was like, okay, well, it's kind of lame to have a bachelor's in nursing and not have actually worked as a nurse. So I actually moved up to Davis. I got a job at UC Davis. I worked on the pediatric floor for 1.5 years as a nurse. I finished up like the last couple of labs I had to finish up for physics and applied, and, thankfully got in, right? And what I want to say about that time in my life was that the entire time I knew I want to go to medical school, and I had people in my life that were like, gosh, it's going to be really hard. And I really had to fight the urge to, one, believe them, and I had to fight to continue to believe in what I knew was going to be the right thing for me. Like, because I knew going through nursing school, I was like, gosh, I can tell like this, what I'm learning is very surface. And what I want to understand is everything deep about it. Like, I want to understand why, like the very core reasons of why things are happening in the body, in disease, whatever. So there was that. And if you ask my parents, they will not remember this. They will not remember that was what it was like during that time. They'll be like, oh yeah, she decided this and she did that. It was so great. It was so smooth. And there was a lot of tension about, feeling held back by my own parents. Like, I felt really underestimated and held back by them. But that was probably the thing that fired me up. Like that counselor to my brother that was like, oh, that's not happening. I felt like that was what my parents were giving to me. And I was like, but you don't get it. Like, I'm way smarter than than my brothers. But anyway, so that was undergrad. And then, med school ended up being not easy, but it was helpful to have that clinical application beforehand, right? So when I was going through that first 2 years, they're like, oh, well, that's why this thing's important. And that's why that thing's important. And that's why that biochemical pathway is important. So it helped to do that. And then when I got into the clinical years, like, it was a lot easier to like quickly jump into that role and be like, okay, this is where I fit. This is where I understand where this process works. I understand how all these pieces work together and how to get care done for patients. So in the end, it ended up being a good plan. And so I have to give my parents in the end, props for like, pushing me to have this experience, because in the end, it probably made me a better doctor.
Hey, Dr. Andrada, I had a question about the residencies that you did. I'm not sure like what like the residency or fellowship that you had, but I heard like some people could do like a pediatric residency and then do an EM fellowship, or an EM residency and a pediatric fellowship. So I just wanted to know a little bit more information about like the process of like how you did it, and if the two things that I said earlier are things that exist.
Yes, all those exist, and actually like two other versions of that. So there are two ways to get to a pediatric emergency medicine board certification, right? So the American Board of Pediatrics is the one that owns the certification for you are a pediatric emergency medicine board certified physician. And so the two ways that you get there is by one, after medical school, doing a 3-year general pediatric residency, and then applying into a pediatric emergency medicine fellowship, which is another 3 years, right? So you do 3 years of general peds, 3 years of a PDM fellowship. So if I do 3 years of a general pediatric residency, then my PDM fellowship looks like an emergency medicine residency, right? Because the pieces that I have to fill in are the things that the EM residents have done: toxicology, plastics, ortho, trauma, and then lots of time in the pediatric ED. Now, if I'm an emergency medicine resident and I do that residency, I can also apply and do a pediatric emergency medicine fellowship. Most of them are a little bit shorter. They're 2 years. Some of them are still 3, but guess what their fellowship looks like? It looks like a pediatric residency, because they have to fill in all those gaps that they didn't get when they were an EM resident. So they have to do the neonatal ICU, the pediatric ICU, the pediatric ward service, the pediatric cardiology clinic, the pediatric nephrology clinic, and lots of time in the pediatric ED. So that's how those two things look differently. And the way for me that broke down was like, I never, ever wanted to see an adult ever again. Like I was like, those people are scary. Kids are my people. And I'm good with never seeing an adult again. So that broke down. That was a very easy decision. Now, from a financial standpoint, from a job standpoint, you're way more hireable if you go EM, PDM, because you can get hired anywhere, right? Like Kaiser, any community, any academic facility. If you go EM, PDM. If you go peds PDM, there are very few community facilities that will take a PDM person, because we can only see, 30% of that volume. Most EDs are seeing about 25 to 30% volume of kids. So we're not as hireable, but so that means that most of the PDM people are in academic facilities. So then the other way to get there is if you do a med peds residency, which is 5 years, but you can't sit for the PDM boards, weirdly. So there's all these weird concoctions. So like if you're heading down that route, just like ask someone, just like, okay, if I do this route, can I take the PDM boards, right? It's weird for the med peds people to not be able to take those boards, but they're just like double boarded, but they don't have a PDM fellowship. It's very confusing.
Yeah, I was gonna say, I'm so intrigued, but so confused at the same time.
Well, I would just say the first question you have to answer for yourself is, can I see adults and kids, or do I just never, ever want to see an adult again? That's the first question.
Mm-hmm. Okay, thank you.
All right, I have a question. How do you deal with a patient whose parents refuse to undergo treatment or follow-up or medications?
Good question. So the answer to that is, your first step is something called shared decision making, right? So there's a whole spectrum of how to deal with families like this. One is shared decision making, right? So you share the decision, we talk about, why these things are important, what happens if you don't do certain things, how limited your understanding is of the problem if you don't do all the testing, and how limited the treatment is if you do or do not treat, and what the risks and benefits are, right? And then we try to come to some middle ground. If if the parents are making a decision that is a life-threatening issue for the kid, so the standard example is like a Jehovah's Witness family, the kid has leukemia, needs a blood transfusion, or they will die, and the parents are like, well, it's against our religion, so we're not gonna provide blood. That's a life-threatening situation. And then you have to take the legal route. So in that situation, we get a court order. So we go to the social worker, they call a judge, they get a court order, and you just have to put those pieces in place. Life-threatening situation, the family is refusing. We take over care of the kid. We take over, like the kid is now in protective custody, and now we can make decisions, the right, the best decisions for the kids, right? So that becomes a legal intervention. The other issue is that if, say, like in this butane hash oil thing, it's a safety issue in the house, then that becomes a protective issue, custody, because again, because the situation at home is not safe, right? So if there's an abuse issue, physical or sexual, or something like this, where it's just like, there's crime, there's criming happening in the home and it's not safe for kids, then that kid gets removed by CPS. So, so if it's things that are less than life-threatening or just like physical safety in the house, you want to work to negotiate and compromise and, make sure that there is clear understanding. Now, there's certainly families that are just like, well, yeah, you're telling me that there's a fungal rash, but I don't want to use that antifungal cream. Okay. Like, we can't hold the kid for that, and we can't remove custody for that. We can just be like, well, I guess that rash is going to get worse, and you'll come back. And, and really the right thing to do in that moment is decide, okay, well, we can't do anything legally. And we just say, hey, that's fine. Just know if it gets worse, which it's likely to get worse, you're welcome to come back. If you change your mind, come on back. Or here's the prescription. If you change your mind, go fill it. Then you have it. I know you don't want to now, so you just want to try to mitigate as much as you can, and, give them steps to be able to come back and not feel judged or humiliated if they do change their minds.
Hi again.
Hi.
I just wanted to ask, how do you think working in your line of work has affected the way you raise your kids?
Oh my God, you should ask my kids. But as I alluded to in the talk, there are very, very common injuries that we see that I think people underestimate as far as, injuries that really impact kids' lives, in very, very deleterious ways. Like just a simple one, seatbelts, right? So like, you become maniacal about seatbelts because that's like the number one killer of kids, right? Is motor vehicle crashes. And almost always the kids that end up dying in motor vehicle crashes are inappropriately restrained in the car. So you become super vigilant about that. We've never owned a trampoline because every time I see a kid that has gone to Sky High or any trampoline park, comes back with a broken bone. What other things? Choking. Like, my kids did not eat hard candy till they were 10 or chew gum. And they, would like be so angry at me at Halloween. And, whenever they go to birthday parties, like, I can't have any hard candy because my mom thinks I'm going to choke, and they just, but when you realize, when you see the stats of like, okay, well, the number one food, the number one cause of death by food is a hot dog. And just think back to any party you've gone to for any, like 1, 2, 3, 4, all the way up, kid party, there are hot dogs there, right? Number one killer of kids, by food. Like, who's like, no self-respecting, PZM doc is going to have a hot dog at any of those parties. Or if you have a hot dog, you're going to like cut it up into these tiny bits. What else? Pets, right? Like, I spent my last shift like sedating a kid so that plastics could sew up their face from a dog, right? A dog bite, right? So like my kids now are like, well, why don't we have a dog? And I'm like, because like, I literally spend so much time just like putting back to kids' faces back together after they get mauled by some dog, right? So like, yes, there are probably the great majority of dogs are fine and they've never mauled a kid, but like every dog injury I see is like horrific. So yeah, so we know we don't have pets, we don't have a trampoline, and we haven't had hard candy. We have it now because they're older now. So they're weird, quirky things, but.
Dr. Andrada, I just wanted to know, what is the strangest thing you've seen lodged in a child's body, or like the most surprising thing you might have found come into your ER?
Okay. So there's so many of these stories. This can be on YouTube, huh? Okay. There was a kid that came in with bloody urine. Normal kid. Kid that came in, bloody urine. Mom's like, he's been having bloody urine for a couple days. He's got this crampy belly pain. I'm like, oh, crazy, right? So we check his urine. It's got a ton of blood in there. And then we ultrasound him because we're looking for what we think are going to be renal stones, kidney stones. And then we get an image of the belly, and there are 12 perfectly round, completely uniform, very dense objects in the bladder. Right? And we're looking at it, we're like, now those aren't stones, because the stones are all very irregular. They're magnets in the bladder. There's only one way in from the external world into the bladder, but there were 12 magnets in this kid's bladder. So, you know, you guys can fill in the rest of that story. But, you know, like urology had to go in and take them out because they weren't going to exit anytime, right? But they got inserted, and it was nuts. It was nuts. And the kid never, he was just like, yeah, I don't know why my urine's bloody. I have no idea. So what? That's probably that's the most recent and bizarre one. On the adult side, there are a lot of very, very strange, weird things that people insert into their body orifices. I had one gal that she literally forgot 3 tampons. She was like, I don't know why my belly is hurting. Okay. So we do a pelvic exam. I was like, how about this? And what about that? Oh, how about this third one? She was like, oh my gosh, I totally forgot. Like, oh, okay. I know, it's bizarre. People are bizarre. This is, you know, this is the beauty of the emergency department. It is the great equalizer, right? Like you just see every walk of life, you know, from, you know, very high socioeconomic status to very low. And it is all this even playing field, right? And to me, the appropriate priorities are in place. You spend the most time, you know, intervening and caring for the people that are the sickest. And then you have the ability to provide, you know, I think, services to every walk of life, right? Like if you just see like the span of cases that we talked about today, like all those pieces are available in the emergency department, and they're available immediately, and they're delivered in a way that just like you know, addresses the problem in a timely fashion. And I would say, like in general, I tend to be sort of you know, a fast thinking and impatient person. That's kind of my default. And so this was the only place that was ever going to be satisfying for me to work, was to be able to figure things out quickly and intervene quickly in an effective way.
Okay, Dr. Andrada. As we wrap up this Q&A portion, I have one last final question to ask you. And you probably heard this question multiple times already from FAC Health Conference and office hours this past quarter. But as FAC tradition, we always ask our speakers a final question of what would be one piece of advice you would give us today and why?
Okay. Just so that I don't bore Jed, I will change up my answer. I have actually 2, and I mentioned one already. One is that, you know, nothing is going to change the fact, and I would never want to change it, that, we are brown people, and that we will invariably be underestimated, at the hands of people that know you well, and also at the hands of people that don't know you well. But you want to understand that that is powerful for your life, right? That is powerful in a way that you can use that to harness motivation and just sort of firepower for what it is that you decide you want to do with your life. So being underestimated, as I talked about earlier, was probably a gift. Because it made very clear to me the things that I wanted to accomplish in my life. The other thing that I really wanted to share with you guys is advice that I wish that I knew when I was in college, and probably when I was in high school, and I did not learn until maybe like 5 years ago. And I was like, why didn't anybody tell me this in high school or college or med school or residency? And the issue is this: like, we all have particular ways of studying that somehow get handed down to us, or we just sort of default to these things that are like how many of you own multiple highlighters and like highlight and read and reread and feel like, okay, this is the thing that's going to help me to know this, right? And so I would really, really, really recommend this book called Make It Stick. The author's last name is Brown. It has kind of a light turquoise cover to it, but it talks about 6 very powerful learning strategies that if you use them, 1, you will spend less time studying, and 2, you will remember things better. And they're not gimmicky. They are heavily studied. There's tons of evidence behind them. But if you switch up the way that you learn to the strategies that they talk about in this book, like, again, they're very heavily, there's a ton of evidence behind them. You can be much more efficient about the way that you are studying big blocks of information that I know you're all deep into the middle of now. So Make It Stick by Brown. And then those same 6 learning strategies are covered in a podcast, which is called The Learning Scientists. If you go to their podcast, they cover each one on like episode 2 through 6. And, and it's not like heavy duty cognitive psychology detail. It's just like application, like, here's how you do it. God bless you. Here's how you do it. And this is how you apply it. And then there's somewhere in that Learning Scientists podcast where one of the younger sisters of one of the main podcasters is in medical school, and she's using they talk about how she applies it. So I would say I was literally mind blown. I was like, wow, I did that all wrong. All that highlighting, all that rereading, all that me telling myself like, oh yeah, if I just reread this thing, that's how I know it. No. So be smart about the way that you're studying. Use some of these effective learning strategies, or you will have much more time to relax and pursue non-academic things, which is super important too. Things that other things in your life that you like to enjoy and still, do well academically. That's all I got.
Thank you, Dr. Andrada, for that. And as we wrap up this virtual shadowing sessions, I just want to thank you for your time, Dr. Andrada. All your multiple case studies were amazing. They were so insightful. And just a few things, there will be a link down below this video if you're watching this session at the moment. It will be a 5 multiple choice quiz, and you are granted 1 shadowing hour for credit. And that just wraps up our session right now. Again, thank you, Dr. Andrada, and we'll see you next time in the next episode of our virtual shadowing session series.
Great. Thanks, everybody. Thanks for inviting me.